So hello, thank you so much for having us here. My name is Joshua Franks. I'm Special Assistant at South Central Foundation in Anchorage, Alaska. I'll share a little bit about myself here. At South Central Foundation, I started in the RAISE program at 15 years old. So our vision of our CEO and our board of directors was, how do we engage youth, customer owners, where they're at? We want to get them in the beginning so they're interested in health careers, so we can have a sustainable future. So they're grooming, training, mentoring us to take over the world, for their world there at South Central Foundation. So that was about 15 years ago. So I've been working with South Central Foundation for the last 15 years, and I'm part of the new generation that got to watch the transition from the old Indian Health Service run facility by the government to now customer owners, Alaska Native people, American Indian people, owning and managing and running and driving their own healthcare services here. So I'm a product of that investment of time, money, and energy that our healthcare organization has done for me. They've supported me through education, through mentorship. In my current position now, I get an opportunity to work with the leadership across South Central Foundation and then also with the state and federal government as well to help address some of the challenges that we have, that we all face here. And I want to also point out, as the RAISE program is another avenue for our listening, how we hear customer owners, and we're going to share that story today with you as we move forward. So today we're going to talk about customer ownership and customer-driven care, the relationships, coaching, supporting the deliverables of healthcare, and population health and health promotion within a medical delivery system, as well describe the SEF NUCA system as a specific example, and to answer any and all of your questions. So I'll give a little bit of background information about our organization. This is our South Central Foundation Board of Directors. They are all Alaska Native business professionals from various professions. They are also customer owners that are appointed by our tribal authority, Cook Inlet Region, Inc. And like I said, they're all accomplished professionals we have a surgeon, we have a past ex-chief of police for the municipality of Anchorage, who's also currently the chairman of Cook Inlet Region, our tribal authority. We have a nurse in Loretta Throop, and other tribal leaders from around the state of Alaska in our service area. And South Central Foundation currently employs about 1,600 employees at various levels, and we provide services to 65,000 Alaska Native American Indians living in and around the state of Alaska. And I should mention as well that about over half of our workforce are Alaska Native American Indian. So it really gives another avenue and opportunity for the voice of the customer to be heard. Not only are they employees of where they work, but they are also users of the system. Before you, you'll see the mission and vision of South Central Foundation. This is based at the family. We believe family is at the heart of the community and the heart of wellness. Our approach to wellness and how we care for our people is really driven at the family level, including everyone. There's a story that I'll share just quick brief with you. One of our participants, we usually have customer owner panels where they come and kind of talk about the changes that we've seen, but there's a story that one of my coworkers shares that her grandmother was ill, and this was not very long ago, and trying to decide what the best way for care, how should grandma spend her last days. She was at the end of life. And it wasn't so much the doctors and providers giving the direction to but it was to the patient or our customer owner, but it was the family decision. So it was her, my coworker, her husband, their aunts, uncles, everybody was in the room. And over the years, they've built this relationship with their primary care provider. So they were able to ask questions to be able to really help make the best decisions for grandma in her end of days. And so it was really empowering for their people. And that's a story that she shares many times. And I think it's a great example, both at the end of life, and then I have another story that I will share with you for how our young people are engaged as customer owners as well. But mission and vision, this is not just a poster that you see hanging on the wall at South Central Foundation. This is something that we spend a lot of time and energy with our workforce and talking with. So it's created the culture of our organization. We are a family. And the next couple of slides kind of impact, this is all of our kind of organizational structure here piece. Our key points: shared responsibility, commitment to quality and family wellness. The shared responsibility piece means it's not just me showing up to my primary care provider and saying, fix me. It's having that dialogue with one another and building that relationship. Our operational principles here, if you'll notice that they spell out relationships. As you'll see as many of our slides, we love acronyms. They're easy to remember, and they help our workforce really key into these things and believe. This is probably the biggest emphasis that I'd like to make here, because everything that we do, any changes in innovation, things that we want to test out for changes, are weighed against these mission, vision, key points, and operational principles. And if they do not fit, because these were our Alaska Native people, these are at their core values, as part of their core values. So if they don't fit, then we don't do it. Or we look to ways at how we can make the process fit better for the Alaska Native people and not the other way around. I'm going to show you here just a quick brief map. This is the state of Alaska. You'll see the shaded area here is our service unit. It's about 105,000 end to end and about 500 miles wide. There's many remote locations and clinics that we use: behavioral health aides, dental health aides, and telemedicine is a really big part of these, providing services to these areas. And then here's another map here just to kind of show you that we like to show folks who are coming from the lower 48 just how large the state of Alaska is compared to the rest of the United States. All right, so everybody's here for our measures of success. Utilization, we've had a 75% decrease in hospital admissions since 1999, and this is when South Central Foundation has taken over from the federal government to provide health services. We've seen a 71% decrease in hospital days per 1,000 since 1999. We've had a 36% decrease in outpatient visits per 1,000 customer owners, and then, of course, the clinical quality. So we are also accountable for our outcomes. Currently, we have an overall satisfaction of 93% with our customer owners. Right now, we're in the middle of trying a new survey system with them, but we also have tried to incorporate some of as they're leaving the clinic. It's not just so much mailing them a survey at the end of the clinic, maybe 3-4 weeks later, but it's capturing them right as they're coming out to help rate their care and what that specifically is for them. Our overall employee satisfaction is 94%. And our employee turnover rate is very low. And in 2011, we won the Malcolm Baldrige National Quality Award, which is the highest presidential honor for businesses in America. Then and now. So just a brief, if you'll look here, this is the Indian Health Service facility that we had. It was down in downtown. And the biggest thing, the change that we'd like to show here is just how customer voice and input has driven. This was our first kind of impact on how you can tangibly see what the voice of the customer has done. They were involved in the design elements of our new facility. This is our current facility, our hospital, and then our primary care clinic, both 1 and 2. And now I'll turn it over to Dr. Douglas Eby.
Hello. So I am Doug Eby. I'm a doctor, master's in public health. I have a counseling degree, so I do the little mental health thing in the past. But mostly I'm a father, a husband, a son, and a partner with my family and my extended community on healthcare. And I achieved a distinction a couple months ago of reaching the medical diagnosis of obese. So I believe that makes me qualified to speak on pretty much anything I want to in healthcare. The doctor part being the least important part. I was listening to the Minister of Health, and I want to review just a few things. He said that for health, that he touched on the issues of water, sanitation, housing, salt, sugar, mental health, tobacco, fat, safety and transportation, and so forth. And he said that health policy is too important to be left just to the health minister, and I think he's trying to build a portfolio that encompasses the entire government and move it under the health minister. And it's just unfortunate he's spending so many days in bathrooms studying toilets and sinks in order to achieve this goal. Did I get that right? Where's our minister? Okay, that's what I got out of the talk. Actually, I thought he was right on. And our story is going to try and illustrate a lot of what he talked about. He said that there's 4 great big transitions: more elders, more chronic conditions people live with, less infectious disease, more issues related to lifestyle and risk factors that are happening, people living longer with disabilities, and all of the challenges that that brings. And unfortunately, our medical model that we've lived with for the last 100 years is still today, and from what little I know of Norway, I think is true in Norway as well as in the US, is still today mostly oriented around infectious disease, trauma, things that break, things that can be eradicated, and things that can be thoroughly fixed. But 2/3 of what we do in healthcare this day is not that work. Our model is still based on a 100-year-old model of manufacturing, the scientific method, the whole issue of assembly line, understanding disease as related to the body, fixing the parts, and somehow if you fix each part and get a right diagnosis and right treatment plan, somehow health will break out at a population level. It's just not true. And it's especially not true today, and I thought he made a just outstanding case for that being so. So we believe that the medical model really only works for a small amount of what we do in medicine today. But in order to take our workforce and get them to a different place, we have to teach them a different philosophy and a different understanding. And that's what I want to lead you through in just the next few minutes, is what we do around that. I essentially see myself as a cultural broker. We have interpreters who are interpreting to us in English what was being said, and too often we think that's all we need. We need people to use the right words. But we need something much deeper than that. We need people who can understand the people sending information and the people receiving information and broker across those cultural divides, whether it be age, language, attitude, professional training, or people from other countries and immigrants, or different socioeconomic statuses. And the key role, we believe, in healthcare, clinically, is this idea of a cultural broker. And in management with medical professionals, it's the same thing. For those of us who want to create a new reality, this skilling up and being a cultural broker. So services are too big and complex to be left just to medical people. We can't just do diagnosis and treatment. If you don't take anything else out of this talk, I'd like you to remember this diagram. In a high acuity situation over here on the right-hand side, so I'm going to die in the next 10 minutes if you don't do something to me. I get hit by a truck, I'm laying on the street, emergency medical people do things to me, the emergency room does things to me, the operating room does things to me, the intensive care thing does things to me. I, the customer owner or the patient, our word for patient is customer owner, so the patient and family have very little control, and the system has almost absolute control. And in that environment, the medical model works pretty well. We use our technology, we do things to people, and you should lean and Six Sigma and remove waste and Toyota production, that stuff to death. The problem is 2/3 of what happens in healthcare is over here, where really we as healthcare professionals have very little control over what's going to happen. So let me give you an example from primary care. Someone comes to my office, we have an interaction, I give a diagnosis, I write some prescriptions, I give them information, and I send them on their way. Okay, my work is done. But that has nothing to do with actually what really happens. Whether they get the medications is under their control. How they take those medications is under their control. If they cut them in half to make them less harmful to them, if they take them less often because they don't like the side effects, if they share them with their friends and neighbors, if they pull out the pills from last time because it helped me last time, maybe helps me this time, sharing them with people that sound like they have the same thing, all of that is under their control. Whether they use tobacco, how they exercise, what they eat, what their sleep habits are, whether they lash out violently when they're frustrated, how they parent, what their marital status is, how they solve problems at work, is all completely under their control. And those are 90% of the variables that drive how their health is and how they live with those chronic conditions that they're living with. Do you agree? Then why do you perpetuate a system that requires people to call on the phone, wait weeks to be seen, because aging a medical problem must be good or we wouldn't do it. I don't know why else we would do it. And then once you see them, you put them through the same process every time that requires them to get on the scales and get naked and sit in a room with the door closed and wait for someone to come in for 2 or 3 minutes to tell them something, send them on their way, ignore their existence till they come back, and then call them compliant or non-compliant with the medical direction they were given. It's insane. All that we know about how humans learn, how adults learn, how they make decisions, how they drive their choices that drive their outcomes says that's a terrible, horrible model for having impact on their lives. And yet it's what we spend massive amounts of our shared wealth in our society on, a model that intellectually is incompatible with affecting the choices people make that drive their health conditions. Correct? Then why do you perpetuate it? Here's another way of thinking about this. If there's a target on the wall over here and I have in my hand a rock, I can throw the rock at the target and eventually I can make the rock hit the target every single time. Because I have control, the rock is passive, I exert my control on the rock through practice and learning and people observing me and Six Sigma and Lean and Toyota Production System methodology, I can make the rock hit the target every single time. However, if what I have in my hand is a live bird, and no, it's not from that Angry Birds thing on your computer, it's a live bird, and the goal is the bird to get to the target over there, I can push it in the right direction with some force, but overwhelmingly what decides whether the bird ends up at the target is under the control of where the bird decides to fly. Right? And in healthcare, 1/3 of what we're doing is throwing rocks, and 2/3 of what we're doing is dealing with birds, because they decide whether to go to that target. Now, I can get the bird to that target much more likely if I understand what's important to that bird, what are its values. So if I put a house, bird seat, or its babies over there, it's way more likely the bird's going to end up there. But the only way I know that is by knowing the bird deeply. What are its assets, what are its drivers, what are its values, what's important to the bird, and making the target become attractive to the bird. It's not my agenda, it's the bird's agenda. Does that make sense? Okay. This is another way. So this is what we teach our staff, because doctors and nurses and pharmacists have been to school so many years, and they have been brainwashed into a culture, into a methodology, a way of understanding, a way of interacting with people, a way of diagnosing and treating that is completely culturally biased and culturally based. Okay? And since a lot of you come from that culture and have been brainwashed, I have to take simple ideas and put them into complex charts so you won't understand them. It's true. So this actually is a pretty simple chart. On the x-axis on the left is the amount of certainty or agreement as to the very best way to do something. And you notice low is at the top and high at the bottom. And on the x-axis is variation, high on the right, low on the left. So in situations where you have a process you're trying to improve, where you can drive variation down, and you have a high degree of certainty or agreement as to the very best way to do that activity, you should standardize, you should protocolize, you should make everyone do it the same way, and you should beat up the people who don't comply. And I do agree with that. And that's about 1/3 of what we do in healthcare. This is why in hospitals we've driven down central line infections, ventilator-acquired pneumonias, catheter-acquired infections, post-operative surgical site infections. All kinds of things we've driven down to levels we thought were previously impossible. This is the whole patient safety movement around which healthcare has spent 90% of its effort in the last 20 years, is to standardize things, to reduce error and variation, to make it safe. And that's fine as long as what you're doing to begin with is the right thing to do. We won the Baldrige Award, in my opinion, not for doing that, but for instead preventing people from getting into the medical system where more harm and over-application of technology can occur at massive cost. So we try and live in this area, which is where 2/3 of healthcare is, where variation is moderate and certainty is only moderate. So a newly diagnosed diabetic, and by the way, adult onset diabetes is a complete fabrication of modern medicine, but we can talk about that in the question and answer time if you like. But if you have a 50-year-old person with newly diagnosed diabetes, and there's a fair amount of variation about that person, is he male or female? Does he have employment, transportation? Does he have a social support system? All of those things are variables, and the amount of agreement as to the exact best way to treat him is moderate. Do you start medications aggressively, then lifestyle? Do you lifestyle, then medications? Do you titrate up rapidly? There's not a single best way to do things. There are better and worse ways. It's not that there's no certainty, and it's not that there's infinite variation. There's moderate degrees of both. And 2/3 of what we do in healthcare lives there, and that does not lend itself to rigid standardization and protocols, and never will. It's a messy, messy human business. And the skills for training staff, getting them on board, orienting them, and then driving excellence are all around messy human relationships, conversations, pull systems for quality, transparent data use, and that sort of thing. Whole big conversation we don't have time to get into in much detail today. So here's the reality. In healthcare, it is a longitudinal journey across decades in a social, religious, and family context, hugely influenced by the voices around the people who are living their lives. They're getting a lot of information from the internet, from TV, from their coworkers, and so forth. And if we don't figure out how to create a longitudinal platform that effectively partners with them on their journey to make different decisions over time, the entire system will fail to be efficient, it'll cost tons of money, and it won't produce very good outcomes in the end. Certainly not population health and public health type outcomes. So we believe that we are not a manufacturing and product industry, but we are a service industry based on relationships, and we have to completely rethink for that 2/3 of what we do. Now, 1/3 is fine. Trauma, infectious disease, a lot of things you do in intensive care units. The mechanical model we have is fine, but for most of what we do in healthcare, it's not fine, and we need to get to a relationship-based system that completely rethinks how everyone thinks and acts, is rewarded, and how we track data and excellence in healthcare.
All right, back to our story here. So before, here we go. So this is the kind of capture about 15 years ago when we started this journey and involving the customer owners in driving the decisions of their healthcare. What they were saying, customer owners were frustrated. They were waiting, impersonal, paternalistic, crowded, and unfriendly. When I was young, in the old system, we'd have to go all day. The emergency room was the entry port in order to seek any kind of services at the old hospital. And we use the old hospital, now we have the new hospital. And my mom would have to take off all day. She'd take up both kids because if one's sick, might as well bring the other one in because you're going to be there all day and see if there's anything that we can do, The clinical staff were also frustrated, so our employees were saying, there's too many people, not enough time. And there was no personal relationships and too many demands on their time. And of course, the management was frustrated as well. There was lots of unhappy people, it's hard to motivate the staff, poor financial performance, and challenging facilities. And one more bullet that's not on here, but I'd like to share, is our government was also frustrated. The Indian Health Service is the vehicle in which provides the services to Alaska Native and American Indian people across the United States. And what they found was that if the Alaska Native people managed their health care, or better yet, if they owned their own health care, they had a greater chance of improving their health statistics because it's based on their core values, their people, they're driving that. So that's when we stepped in and we took over management and ownership from the Indian Health Service. So customer owner, I'm going to spend just a little bit of time on this. Why we use customer owner versus patient, client, or just customer. So like Doug had mentioned on his previous slide here too, was that we are a service industry. Now for us, one of the big things that we looked at is, we have a Nordstrom, and it's a clothing retail outlet store or department store. I'm not sure what the one here in Norway is, but they have won numerous awards about their customer service. When you walk in there, you're greeted, you're asked what are you looking for, what are your likes, what are your dislikes, and they help you kind of find what it is that you need, that you're looking for, that you came in that day. And so that kind of level of customer service should be, we found, our board of directors at the time said, well, let's go find out what other places are doing that. So our board members and some folks went to Disneyland or Disney World because they have a culture there that they believe that everybody should have the best time in that. So, and it's not just the folks who are interacting daily, it's everyone. There's a story about one of the street sweepers there. He, happy, and they were asking him, why is he happy all the time? And it's because he wanted to create a magical place and an experience for the customers who are coming here. The big piece here, switching now to owner, why we use owner. I am a customer owner of our healthcare system. I am responsible for my healthcare. That's something that I think has been a big shift for me, coming from an old system to a new one, and how I view my own healthcare. Recently, or a couple of years ago, I went in for a cholesterol check. It was a little high, but I had talked with my doctor, and I've had my same primary care provider for over 10 years now. So he knows me. He knows what my habits are, how I eat, how I diet. So the conversation wasn't so much about, here's the medication that we can do to help you lower that. It's, all right, well, I already see that you're exercising, you're eating, you're that. Let's keep continuing doing that if you'd like. I can offer this to you, but there are side effects in that piece. But over the time, and then he gave me the option, do you want to come back in 3 to 6 months or a year? Let's see how this goes here. And then it was on me to make the decision to continually go back and know, because I'm not a big medication taker person. I'd like to try to control it through diet and exercise because I learned that's the best way. And the positive side effects outweigh all of the negative side effects on that. So the other piece in this is that they drive the changes that we have at South Central Foundation. It's that relationship. It's our listening post for the RAISE program, for all of our different advisory councils and that, and we'll go into a little bit more detail later today in the parallel session. All right, key improvements, our leadership. Our leadership was a big... we needed to have the leadership, because without your leadership believing in this and making these changes, we couldn't have the system that we have today. All of our leadership, or most of it, is Alaska Native American Indian, and they work together. They're the voice of the customer. They have families. One example I like to use, if something doesn't go well for one of my family members, I'm going to hear about it, and since I work at South Central Foundation, it's my responsibility that it gets fixed, and then I have to follow up with them. So this shared responsibility, that it's not just the leadership sending down, but it goes both ways. It's hearing what our customer owners say, following back up with them, but also setting those directions in there. And role modeling this for our president and CEO is a very great role model for how customer ownership and leadership combined. She is always constantly in the community, asking, talking questions, and really working with the people to follow up with them. And she'll go to one event, and then 6 months later, somebody will get to her and say, remember I talked to you about that? And then she'll say, we've been working on this, and we'll follow up back with her. So that's a really big thing. The functional committee structure I'll show you here illustrates that here in a little bit. We took it from a very top-down or top-heavy hierarchical and kind of diffused some of that responsibility for the operations, the day-to-day stuff with our staff and our workforce. I think that's the next slide that's coming up. No, not yet. So again, back to all of our mission, vision, and key points. We must role model these for our employees and staff, and also for our customer owners, because they're looking to us and how we make changes and how we follow up and how we listen in that. relationships across the organization. All of our employees talk to one another. We have to create a common language that they can start working with to better understand each other, to work together, as well as how to engage with the customer owners as well. So here's the functional committee structure that I shared with you. It's a little blurry up here. You'll see the vice president leadership team, which there are 6 vice presidents and then our CEO. And then we've got our operations committee, which does day-to-day stuff, our quality improvement, our quality assurance committee, our process improvement, and our, quality assurance, quality improvement, and process improvement committees. And these are all not just quality people, not just process improvement people, not just managers and directors. These represent on all of these, and the yellow boxes are the subcommittees, are from the frontline staff all the way up to the vice president leadership team. The vice presidents are executive sponsors, so we get the voice from frontline staff. What are the customer owners saying? What's that? And how do we take that back in how we make decisions and drive change? So earlier I talked about how our mission, vision, key points, and operational principles drive all of the changes. And if they don't fit the changes that we're trying to make within these, if they're not weighed against and they don't work, then we don't do it. But if they do, then that's something that it's really based in these here. So this is just a quick visual to show you how it works here and how complex it really is on how we do this. So on top, we have our mission, vision, key points, corporate goals and objectives, which are set by our board of directors, but they're based on customer input in that, and their customer owners as well. And then we have, of course, our functional committee structures and how that, and it goes all the way down to the employee. So in my performance development plan, which is your annual employee plan, they're all tied all the way back up to the corporate goals. So I know how each thing that I'm doing that's in my plan relates back to the overall mission, vision, and key points of the organization. So I understand how that works together. So customer focus. So like I had mentioned earlier too, with our governing board, they are all customer owners. We are constantly getting, and they're highly involved customer owners in how we do this, especially around research and all aspects of this, but I'll use research as one example. They ask really difficult questions. They get research proposals all the time, and it's how is the Alaska Native American Indian people, who owns the data that comes out of it, how is it done, how the research is conducted, and that. And if it doesn't fit based on these mission, vision, and key points, they will not approve it. So we're not just doing research for the sake of research, but we're doing it for the fact that we want to make sure that it is the best possible research for the Alaska Native people and that they own it. The other thing that I'll mention here is the advisory committees. We have advisory committees for everything, or a lot of things. We have an elder traditional healing that is a group of elders that sit in and give input into how traditional healing practices should be done and how the clinic gives some direction to that. We have a Family Wellness Warriors Initiative, which I'll share a little bit later on in the parallel, but that's dealing with ending domestic violence, child abuse, child neglect in this generation. Not a core component to our hospital and medical system, but it is a very important impact on those health statistics in that. So how do we do that? So they have a committee that is of elders, middle-aged, and youth who sit on this and give direction and input on that piece as well. Our customer service committee is very large, and it is, like I said before, another one of our committees. It's frontline staff all the way through and up to director level. And they're all customer owners. How should we best provide? And how do we deal with when we get complaints and things that come through? What's the best way to culturally appropriate to do that? And then we have our men's wellness. This is a newly formed committee here, and it's to address men's health issues here. So how do we talked about common language? We believe in core concepts. This is a 3-day training that all of our employees go through with our president and CEO. She leads them through 3 days, and it's to create that common language. How do I share my story with you, and how do I receive your story? Because the idea behind it is if I know your story and you know mine, our interaction and our relationship and chances for connection will be greatly impacted, and we'll be able to build that trust in that. So we really definitely, this is mandatory for all of our employees to go through, and it teaches them just kind of similar basic back, how do we connect? How do we do some of the training in this and the academia part, and to actually get back to connecting with one another. The other big piece here is workforce development. I'm just going to touch on the interviewing. We use behavioral-based interviewing. It's about hiring the right person the first time around. So asking those questions, really digging into how they relate and work with their past relationships, their past employers, because in our organization, we believe that we should hire that person, and they should be the top choice, and hiring the right people first.
All right. Josh has taken, so we have this philosophy piece I talked about before. You understand kind of our context. Josh has run through a whole lot of different things that we do structurally differently as a result. Different skills, different training, different language, different structure, all the way through the whole system. We're not going to have time to go into much of the details now. This afternoon we have a parallel session where we'll give you some specifics about how we organize our work around redesigning the entire system. Things like the integrated care team, where we use very extensive use of extenders. So the doctor really becomes kind of the coordinator. The analogy I like to use is they've quit being the violin player and they become the orchestra director, so that behaviorists, dietitians, pharmacists, medical assistants, and so forth do most of the work in the exam room and most of the work on the phone and on email. Life is changing in our society, and if we don't figure out how to use iPhones and texting and communicating with people in other ways, we're going to be left behind, because that's where society is. 2/3 of what we do in primary care is information management and communication. Once we have a trusting relationship, it's really about communicating, coaching, advising, and encouraging. And a lot of people do that better than physicians do, and cost a lot less. So we want doctors to do just the part they're good at, which is really diagnosis and treatment development. And 80–90% of the work we want done by other people: behaviorists, dietitians, pharmacists, lay workers, people we call community health aides, elder workers, home visitation people. And we want a whole lot less to happen in the exam room. And our job is to weave our services into their lives on their terms in ways that work for them, not making them come to our institution every time for getting things delivered on ways that are working for us. Does that make sense? Don't have them adapt to us, have us adapt to them. Different workforce, different care providers, in the home, in the life, through communication devices. And the center of the team system then becomes how they interact with each other around the information, not what happens in an exam room. And in fact, less and less of our encounters with people are happening in a clinic, in a facility, or in an exam room. So this really has huge implications for everybody. Specialists get redefined as truly consultative specialists. Our system should need 9 cardiologists. We have 3. Because they don't actively manage anybody's heart problems. It's all done through the primary care system with them as consultative advisors. So we have way, way, way less, as he showed you some of the data before, dramatic reduction in visits, dramatic reduction in hospitalizations in the emergency room, because we walk with people over time. Specialists become consultants on the back of the primary care system. Mind and body is back together. There's no more separating mental health from physical health for the majority of the population. And then you have niche specialty services piggybacked onto this very capable longitudinal platform. So you don't have community, primary care, public health, and hospital as separate entities. You have one longitudinal platform that everyone interacts with and plays with as a single system built upon the person as they live their life with people who partner them in messy human ways over time. So I'm going to skip through a lot of this. This afternoon we'll talk more about the family wellness warriors and traditional healers. We'll talk more about how we use data and information. We believe in complete transparency of data, have people's names on it, make it public, use a pull system for quality where you use inquisitive curiosity about innovation and creativity, not punitive push quality where you make everyone standardize and protocolize and do it all the same way. This is some of the data that we mentioned before, just to show you visually. This is what was happening with the emergency room visits, and then we took over, and within a few years it plummeted and continues to decline. And we're not talking about 5 and 10% reduction. We're talking about 60, 70% reduction. Same thing in admissions to the hospital, same thing in hospital days. Our staff turnover has plummeted to 1/5 of where it used to be, because now people work in a system that makes sense, where they can get value and feel like they're contributing to people's health journeys in a way that really works over time. And I'm going to close with making this personal to Frank. Frank is a 79-year-old. He's got heart trouble, lung trouble, and diabetes. He lives alone. He doesn't feel very much capable of managing his conditions. He calls 911 on the phone, goes to the emergency room a lot, gets admitted to the hospital a lot. In Norway, you don't have any Franks. Oh, you do have some Franks. Okay. So the usual medical model would say Frank has COPD, congestive obstructive pulmonary disease, congestive heart failure, and diabetes, and he has a primary care provider in the usual medical system, not ours. In the usual medical system, he would have primary care, cardiologist, pulmonologist, endocrinologist, nutritionist, physical therapist, pharmacist, home health, probably about 5 other different people, and each of them have standardized and protocolized their treatment plan and apply it to Frank in a sequential model as he goes to all of these different offices. And the person who's supposed to figure out his 25 medications and his 75 instructions is who? Frank. And of course, Frank is a highly, highly skilled coordinator of complex things, right? See, this is the other little dirty secret in healthcare. 1% of the population consume 20% of the resources. 5% consume 50%. 20% consume 80%. The people consuming the majority of healthcare are not the highly functional, the highly organized, the highly capable, and the highly socially supported people. They're primarily the more dependent, more passive, less capable people. And we keep designing systems as if everyone is individually capable, and if we just give them some self-care tools, all will be fine. It just doesn't work that way. So in our system, we would say that Frank is in control, he's making the choices, and no one's really organizing the system around Frank. They're optimizing each of their protocols in each of their specialty areas. So we would say his primary medical diagnoses we want to get paid for are loneliness, isolation, insecurity, confusion, dependency, and lack of confidence. Main clinical medical diagnoses. And we need to mobilize our staff and resources to address those issues. And only secondarily does he have heart trouble, lung trouble, and diabetes problems. So our main interventions are around coordinating with him, supporting with him, connecting with him on his journey, learning his motivators, and helping figure out around him what makes the most sense. And if he can only handle getting 5 medications right, then we better figure out the most important 5 and get rid of the rest of the 20, because giving him 25, he's not taking any of them right. And there's so many side effects compounding all of it that he feels worse. So he quits taking half of them and makes his own choices anyway. So the standard of excellence is defined by him. What can he do? How can we support him? How can we get services to him on his terms? And he has all of that figured out around him. Same-day access, phone, email, in person for anything he wants. We offer that to 65,000 people now, to the same integrated care team of an array of people, and the people with the best ability to do this work are the ones doing the work, which often is not the doctor. And at the end of the day, this is what Frank says: they give me what I and my team have defined I need, when, where, and how I want to need it. They really know me and care about me. They listen to me, they advise me, they support me on my health journey, and my questions and my concerns are answered, my care is coordinated, and my values and goals are what drive my health plan. So we'll leave you with a picture of the campus. Just to close, we don't want our medical providers to be heroes anymore. We want them to be partners, supporters, advisors, and coaches, and we want the customer owner
to be active, not passive, take responsibility for our own health care, which I do, and I feel empowered to do, get information, ask questions, and know my story and our goals of as I work. So a little bit, no longer are we just a hospital where people come to get fixed. It is a cultural hub now for them. They come just to see who's there sometimes and connect with people and build relationships.
So more details this afternoon in the parallel session about the structures and the programs and so forth, but hopefully we've helped you understand a different philosophy leading to different outcomes and different performance in a really, really short period of time.
Yeah. Thank you.